UCL Glaucoma Seminar. As you will know, this morning we have Professor Gus Gazzard, who is Professor of Glaucoma Studies at UCL Institute of Ophthalmology and a consultant ophthalmic surgeon at Moorfields Eye Hospital. He's also the Director of the Glaucoma Service at Moorfields, and most recently he'll be most famous for completing a very important landmark trial which will help us manage our new glaucoma patients. Later on this morning, we have Sheila Luck, who's a fellow in the glaucoma service at Moorfields, presenting a case. And then Giovanni Montesano, who is a research fellow both at Moorfields and City University, who will be sharing some of his research, teaching us how we can recruit patients to have most efficient clinical trials. So kicking off with Gus, thanks for being with us today, Gus, and we're excited to hear about some new outcomes from LIGHT and maybe even more reasons why we should be doing that. Thanks, Gus.
Thanks very much, Anthony. So what I'm going to try to do this morning is a brief recap of what LIGHT is, where it came from, why we did the trial, and the headline findings from the trial for those who aren't familiar. I'm not going to dwell on those for too long because I know that many of you are familiar with those, and I'm going to move on to some of the findings which are somewhat newer than that, and what that might mean for the implications for those for some of our treatment choices. So Anthony, thanks very much for the invitation. We've headed this new outcomes from LIGHT. Should I be doing more SLT? There are funding acknowledgements for the trial and the piece of work which has been going now for well over 8 years. Primarily it was funded by the HTA from the National Institute of Health Research, but there have also been additional funding bodies involved, including Fight for Sight, Eye Charity, the IGA. The large number of people involved in this. This can't be an exhaustive list because the text gets too small, but primarily these are the local investigators, and many thanks to also particularly Amanda Davis and Neil Nathwani and Evgenia Konstantopoulou, who have been really instrumental in keeping this trial going and on track, because it's a huge piece of work. So the title was, should we be doing more SLT? What's always interesting about these things is looking back at what was happening when we started the trial. In fact, in the couple of years that we took to set up the study, there were very few laser trabeculoplasties being recorded in England. Here's the total number of hospital episode statistic cases for laser trabeculoplasty in total across England. And back in 2011, 2012, when we started recruitment, there were just before that there were fewer than 1,000, and as we started, the numbers have steadily climbed from there. And this is all prior to the LIGHT trial actually being published. So this is for us finding out the results. There was clearly an increased appetite and several-fold increase in what was happening. So it'll be interesting to see what happened after this. But clearly, the act of doing the trial itself may have influenced this. So should we be doing more laser? Well, we were doing more laser, more SLT, even before we had really proven that it seemed to be, in some circumstances, a good thing. So I think that's an interesting context. The trial primarily is the main publication, if you wish to look it up, is in the Lancet from March of last year, and we did this because the problem with standard medical treatment is that a lot of patients simply don't use their medication in the way that we would like them to. If you monitor how often they take their drops, if you look at their prescription records and how often they've got their drugs available, or if you look at large studies in the US, you find that a huge, quite staggering number of patients simply don't have the medication. Some of them some studies up to 1/3 of patients don't have the medications you think they've got. Whereas we know that we've done the laser for a patient. Even if not everybody responds, we know that we've at least got 100% or near 100% compliance in patients agreeing to have laser actually receiving laser. So we know where we are with it. We don't have the problem with patients being prescribed eye drops, but potentially they're not using them. So the theory of laser, just to briefly recap, is that the laser beam applied to the trabecular meshwork back in the day with ALT on the bottom right down there would cause a small contraction burn, and it was thought that that was somehow important. But then lower power laser, causing much less damage in these electron micrographs of human trabecular meshwork, seem to also lower the pressure. And the theory is that an inflammatory response starts that stimulates cytokine release, monocyte macrophage recruitment into the trabecular meshwork, and that this helps initially with the Schlemm's skull conductivity, but also leads to long-term changes in the trabecular meshwork, probably due to phagocytic activity of those cells clearing some of the debris, but also a long-term permanent repopulation of what is otherwise a hypocellular trabecular meshwork. And it may be that it also stimulates some of the trabecular meshwork stem cell precursors that Legion Draco has described as residing within the trabecular meshwork, such that some of the original precursor cells are stimulated to divide and repopulate the trabecular meshwork. So there seem to be short, immediate, intermediate, and very long-term changes. And anyone doing a lot of laser has examples of some patients who have received treatment and maintained pressure control for many, many years. I always remember Anders Heil saying that he thought ALT was the old-fashioned ALT was an excellent treatment for many of his patients, and he had, a number of different patients who had treatment, and well over a decade later, they were still controlled. They'd clearly had high pressure on more than one occasion, and yet they were still controlled over a decade later. So clearly there is a long-term permanent alteration to the outflow obstruction which occurs in some of these patients due to the actions of the SLT. So the trial itself was SLT in laser and ocular hypertension. We looked at health-related quality of life and other outcomes. It was a 6-center trial with 718 patients, initially running for 5 years, but we extended the follow-up by a further 3 years. So we now have a 6-year follow-up. We pretty much included everyone with open-angle glaucoma or ocular hypertension who required treatment according to the NICE guidelines. There's no IOP criterion, so we included NTG or normal pressure glaucomas. And we excluded very advanced glaucomas because we weren't sure if it was going to be enough for them or if it was appropriate for them, and obviously secondary glaucomas and people who couldn't take drops or laser and therefore couldn't be randomized. And we randomized the patients 1-to-1, powered on the basis of the EQ5D quality of life difference. And we treated in pursuit of a specific target. So we aimed to lower the pressure to a preset target pressure, which was defined and refined for each individual patient. The laser protocol was standardized across all sites, and we tried to standardize the clinical endpoint of being the just visible presence of bubbles on at least 50% of the shot, without regular free streams of bubbles. The video here shows probably slightly more power than I would normally be used, with very prominent, very rapid streams of bubbles appearing at the trabecular meshwork. That's perhaps slightly more than we were standardizing to. But that was courtesy of Philip Denis, who shared the video. And certainly there's a wide variation across the world in quite how much energy we use. But we wanted to use enough energy, 360 degrees, but not very high power. We incrementally escalated the treatment through the 2 different pathways. So while the laser first pathway had up to 2 SLTs, and the medicine first went straight into medicine, but both groups could have an escalation through the prostaglandins, beta blockers, and others, if not contraindicated, leading right up until surgery if required. We had some standardized target setting protocols, and then we had some standardized protocols for reaching, attaining and maintaining target, and we wanted to make absolutely sure that these were real instances of the eye pressure being measured above the target and not simply variability in measurement error or diurnal fluctuations in the patient. And so if they were only a little bit above target, we rechecked the pressure on a second occasion to make sure. If they were a lot above target, 4 or more, then we accepted that that was a true deviation from target, and we escalated treatment. So we screened a lot of patients for eligibility, and a couple of people have asked this in the past, why so many screened for 718 randomized? And that's because the majority of these patients simply didn't meet the inclusion criteria because they'd been previously treated or they had other diseases. So we didn't include people that had active diabetic retinopathy, were about to have cataract surgery, or had already been treated for open angle glaucoma, for example. So it wasn't that we had very stringent criteria, we had very open criteria, but we wanted new patients. And we hang on to 91% of the subjects that we recruited, having worked so hard to get them. And we managed to do that with a lot of hard work, phoning them up and sending them the questionnaires and bringing them back into the clinic. Around 3/4 had glaucoma, and of the glaucomas, around 2/3 were mild, and the others were slightly more severe than that. But the more severe disease is not represented by a very large number of patients in this trial. So this is the milder end of the disease spectrum. So the results, well, the quality of life results, many of you will remember, came out as comparable at the end of 3 at the first outcome point on all measures between the two groups. The clinical outcomes were more interesting. We were expecting the visions to be comparable, the pressures to be the same because we're treating to a target. So if they didn't meet the target, we increase the treatment. As a result, we're expecting, on average, things to be similar between the two groups. There were slightly more visits in the laser first group, but it wasn't significant. The 2-month pressure reduction, this is the last time at which they had no additional, because after 2 months we escalated treatment or repeated laser if they needed it. It was comparable between the two arms, between 1/4 and 1/3 pressure layering, which is what we'd come to expect from a first off treatment for most things. Similar numbers of visits actually at target at the time that they turned up at the hospital. This doesn't, of course, tell us what they're doing for compliance outside of that. If you looked at visual field and or progression as defined within the trial, there were slightly more of those in the medicine first group. There were more cataract extractions in the medicine first, and significantly many more trabeculectomies in the group that started and stayed with medicine, and then if they weren't controlled went on to surgery. And there were 11 of those, whereas in the laser first group there were none. As you might expect, this was partly because they had 2 extra steps, but it also seems to be backed up in the further 3-year follow-up, which is ongoing, in that this marked difference between the two arms has continued. And there was slightly more treatment escalation, so slightly more occasions on which the medicine first group were not controlled and required additional intervention. So it would seem to be that on the basis of this, that the laser first group had a comparable initial control, fewer occasions where they needed additional intervention, and within that, none of them required surgery. So that's quite exciting. And that was really the initial excitement from just over a year ago now. If we look at the clinical outcomes in terms of the numbers that were controlled, of the eyes, if you do it on the basis of controlled eyes rather than controlled patients, 78% of the SLT first eyes were controlled with just 1 or 2 lasers. 74% of patients, obviously some patients had 1, some patients had 2 eyes, and the eyes did not always behave identically. But of these, 3/4 of patients were drop-free and at very stringent, predefined, pre-specified target pressures. Now, of these 3/4, around 3/4 had only needed 1 laser, so about 60% of the total. And of that 74% of patients who were drop-free at the end of 3 years, roughly 1 in 4 had had a second laser. One of the important considerations was safety. We had one pressure spike that required a dose of Diamox out of 776 lasers. So much, much less than had previously been considered to be the case. They all had iopidine at the time as a pre-treatment, as is standard practice across the world now. But these were these were relatively mild disease, and for their first treatment. And I think that's one of the reasons why it was quite so safe. Latina's original patients were often on other medications, multiple medications, and probably with more compromised outflow tracts, and therefore a higher of a pressure spike. Small difference making greater difference, a small difference in outflow facility, perhaps making a greater difference in actual pressure control. If we look at the medications, well, I said that 78% of eyes were medication free at the end of 3 years. What's interesting in the medicine first group is that around 2/3 of these were controlled on monotherapy alone. As I said, these are relatively mild spectrum of disease. So this goes some way to perhaps explaining the fact that there was little difference in the quality of life outcomes. Over time, the intraocular pressure control with those patients having laser gradually reduced. This is a very simple graph just showing the proportions of eyes that were controlled at these pre-specified targets with just single SLT or one or two SLTs over a period of years. If we look at the percentage of eyes that are at target over time by severity, the more severe disease, and this is defining severity by the severity of the glaucoma optic neuropathy, seem to have a perhaps more pronounced tailing off of pressure lowering effect. We're expecting fewer of the more severe disease to be at time with just one intervention, because the targets are defined and predefined as being lower, more stringent, both in absolute and percentage reduction terms for those eyes. So we're not expecting monotherapy to work as well for moderately severe disease as it does perhaps for ocular hypertension, because our target pressures are not nearly as low for OHT as they are for moderate glaucoma. It's perhaps important to mention here that what we're calling a severe group here is severe in the terms of the trial itself. These are not severely very advanced disease. These are just the more severe group of a mild to moderate spectrum within the LIGHT trial. If we look at the actual IOP reduction at 2 months after a single SLT by severity group, we've got total IOP reductions on the left. On the far left in pale blue is all of the glaucoma groups, and then the ocular hypertension groups, and then the following three going across are the glaucoma groups divided by severity based on essentially on mean deviation and some paracentral field loss. And what we see there is that overall the OHT seem to have a greater pressure lowering of around 30%, 8 millimeters of mercury on average, with slightly lower percentage result and slightly less absolute pressure reduction for the more severe disease. And that is interesting because we've defined disease severity by the severity of the glaucoma optic neuropathy, but then the pressure response, the IOP response, both absolute and proportional, is seems to be related to that disease severity. So clearly there's something interesting to think about there. Mild disease seems to have a greater pressure area. So Anurag Garg, who spent a couple of years doing his MD with us and responsible for the next couple of papers, looked at this pressure lowering and looked at predictors of pressure lowering, and in this graph compares absolute intraocular pressure reduction with baseline intraocular pressure, and he was able to show that there are a number of factors predictive of response, but by far and away the strongest factor was baseline IOP. He reported on the safety, which was extremely good as well, and also showed that the total SLT total power seemed to be significantly but weakly predictive of eyes pressure response, but particularly that whether or not they were able to achieve drop-free pressure control at 3 years after a single SLT. So it seemed to be that there was slightly more success in those eyes that had a slightly higher power. I'm not advocating that we should turn the wick up and treat everybody with high power on the basis of this, because we don't know whether this was an epiphenomenon, because it's not actually the reason for the differential risk. It may be that in order to achieve the same clinical response with bubbles at the trabecular meshwork, that you needed slightly higher power in those eyes that had less pigment, and it may be that those eyes with less pigment did better. So it may be that those eyes with less pigment have a better response because of the pigment, and it's unrelated to the actual power delivered. It's just an intrinsic property of that eye. But because we've used a clinical outcome, a clinical response of the laser, we've ended up using more pressure, more laser power in that group. There's probably no way really of knowing that. We tried to grade pigmentation of the eyes on gonioscopy in the trabecular meshwork, but that was not predictive in the study per se. If we look at that baseline IOP, sex was also predictive. Female sex was slightly life response slightly more, and as we said before, total SLT power. What's interesting in the second table at the bottom here, in that the multivariable logistic regression looking at drop-free control at 3 years. So this is those eyes that were able to achieve full control without further laser at the end of the trial. The two-month pressure reading was very predictive of their final behavior. So that's very important, because, and it was interesting and important for us because this was the last time at which we had a completely clean pressure reading without additional medication being used. But it also means that if what they're doing at 2 months was very predictive, so we were able to use the 2-month outcomes in other analyses as a surrogate for what they were likely to be doing later. I think it also means that if we've waited 2 to 3 months to see what the outcome of the laser is, we certainly know that we then have the answer as to whether or not they're likely to respond. And this is for drop-free control at 3 years. This is not for an arbitrary pressure outcome. This is tailored to each individual eye. So the other question we set to ask ourselves was, can we repeat the SLT? And either of Anurag's great papers from ophthalmology, and we took the eyes that had failed within the first 1.5 years, because we then had another 1.5 years within the 3-year follow-up to see how they behaved, and we looked at retreatment and predefined criteria using the standard severity dependent target pressure that we'd used before, and looked at the eyes themselves, but allowing for the correlation between fellow eyes and repeated measures. And we had 158 of the 611 eyes that had laser initially failed within those 18 months, and 115 of these had a second laser, so there were a portion who declined to have further laser, or the consultants thought them out of it, we're not sure which. So some eyes were not at target, did not undergo repeat laser, and went on to medication. So we don't know if that's perhaps a potential bias in this particular analysis. There are some patients who didn't get further laser. The selection criteria for those may be that they had less pressure response than the other ones that failed, but we'll come to that. The total repeat laser power was greater than the initial power, and it seems that those clinicians repeating the laser turned the wick up a bit more than they did the first time. So in this graph, we've got Kaplan-Meier level curves of the same patients. So the initial patients, by definition, all failed within those first 18 months. And then we plot out how they did over the following 18 months, but plotted on the same graph so as to show that they were behaving differently. And the repeat SLT had a much greater persistent success achievement of reaching target pressure than the initial SLT. So clearly repeating the laser Not only did it seem to have at least as comparable, possibly greater pressure layering, but that pressure layering lasted longer. So moving on to the third paper that's come out from subsequent to the actual initial trial results a year ago, we've looked at visual outcomes from the study. We extracted 11,500 visual field of the eyes from the study, having excluded the significant loss, excluded those who had various reasons for a visual field theory. So anyone who had 5 fields in 56 eyes were excluded. So we ended up with about 9% of the total number of eyes had randomized. With a mean of 4 years because of the trial.
Sorry, Gus.
Yeah.
Gus, just 1 second. Your voice has gone a little bit staccato, as some other people have said. I don't know whether it's the battery in your Bluetooth thing potentially, or something. Your voice suddenly went, and Keith noticed it as well. So I think it isn't just me.
Hang on a sec.
That sounds better.
Anthony, can you hear me?
Yes, that sounds good. Thank you.
Yeah. There we go. And just as I was getting to the fun paper as well, sorry about that, chaps. Button if it starts going crackly again. The perils of Bluetooth. So in the third paper, that for which credit really goes to David Wright for the heavy lifting, and much thanks to David Crabb and Giovanni Montesano in particular, for the two of them for assisting with the analysis design. And we took the visual fields from the trial running up to about 4 years, and excluded, as I said, the patients with lots of false positives. There weren't many of those, and the eyes that didn't have many visual field series for a variety of reasons. And then we looked at those to see if there was any difference in the behavior of the two treatment groups. And the way that this was done was using a trend-based rather than event-based analysis, because that's been shown to be more sensitive, and looking at visual field locations, location by location, for both total deviation and pattern deviation values. Now, this clearly involves multiple tests of multiple individual points and multiple series, and it is possible to construct linear models that both the two Davids and Giovanni understand better than I, but that can account for correlations within an eye between individual locations, but also correlations between two eyes of a specific individual, and also can account for the multiple testing, so that you can construct a very powerful but robust and reproducible analysis with these models that that compare the visual field series for the two groups, looking both overall by eye to see whether eyes are deteriorating more. That's obviously what we're specifically concerned about, but also looking to see if visual field locations themselves are deteriorating. And in terms of this visual field loss, there was a comparable distribution of numbers of patients left within these groups. Their baseline characteristics were very similar for this specific analysis. So we've looked again at their characteristics because we've excluded a small number from the original study. And in particular looked at the characteristics of their visual fields. So the number of fields per eye was comparable. There was the median was slightly higher for SLT, 10 versus 9 for the medical treatment group. And we looked at the number of the average interval between those fields, the mean deviation at baseline. The one thing that was somewhat different was there were more cataracts carried out in the medical therapy group, as there had been at 3 years. So you'd have expected that to continue. The difference is perhaps less marked, but 64 compared to 42 eyes had cataract extraction in the medical first versus the SLT first groups, respectively. So if we then look at how the total deviation behaved, we defined, we looked at the progression rate in decibels per year, estimated for an individual eye, and also with all of the individual points considered, and also looked at the individual points themselves, and so we could compare the total number of eyes that were deteriorating, or the total number of locations that were deteriorating, and compare that between the two. If you look at the mean values for these outcomes, what you find is that there seems to be very little difference, but there's a difference in the distribution. So there was a greater number in that left-sided tail in the medical first group compared to the SLT first group, such that there seems to be a change in the number, or a difference in the number of the moderate and fast progressors, the moderate or fast deterioration. And if you look at this, these are the global total deviation progression rates in the graph, top and bottom on the right hand side, looking at the distributions, so that's per eye, and the percentages of the total up on the left there. And you can see that there's a sort of leftward skew of the distribution graph, suggesting that there are more fast and moderate progressors in that medical group. If we look at the numbers of eyes and locations, the numbers over on the left there back up what the impression that one gets from the graphical representation on the right, and that 26% of eyes, 17% laser first group, according to our preset definitions of what were moderate and fast deviation rates. And that was clearly significantly different, and the same thing applied to locations. Now, one of the possibilities with total deviation is that it is perhaps more subject to cataract development. And so if we move on to pattern deviation, which attempts to correct for the any total depression of the hill of vision, but it does thereby exclude some diffuse visual field loss, which is captured by the total deviation, which is therefore more sensitive. So moving here onto the pattern deviation, we see that the same pattern seems to exist, but it's perhaps less marked. The difference between the two groups in the number of eyes that were fast or moderate deteriorators in terms of decibels per year per eye was less marked and not significant, but there was still a significant number of a significant difference between the number of individual field locations which were fast or rapid progressors in the medicine first group compared to the laser first group. So even adjusting for any effects of diffuse depression of visual field sensitivity, be that glaucomatous or be that cataract generated, we saw that there was still a significant difference between the two treatment arms. If we then repeated that with a sensitivity analysis where we censored for the 100 or so patients who had cataract extraction as a surrogate for those patients who were perhaps deteriorating faster or more due to cataract, and the results were comparable. So it did not change the results if we removed the outcomes of those patients who had required cataract extraction during the trial. So that's a very exciting finding, because it suggests that the medicine first group did worse in terms of field preservation than did the laser group. So SLT, for whatever reason, seems to have preserved visual field, particularly in the fast to moderate fast progression group, better. And I think that this is probably a reflection of the compliance within the drops first group, and possibly a reflection of the previously described reduced diurnal fluctuation variation that one gets in the laser group. We also looked in this study at economic evaluation, and this is just really a reminder that laser first came out as more cost effective on a variety of different metrics, predominantly partly but not entirely because of the requirement for greater cataract surgery in the drop first group. But I'm sure certainly if we model that out over the next 6-year follow-up, it's going to be interesting to see whether that persists. We should consider that there are risks of SLT, and just to close up, just literally a couple of slides just to remind us that if we're asking ourselves the question, should we be doing more laser, we have to bear in mind that trials of 718 patients are poor ways of collecting data on very rare or uncommon complications, and hopefully the forthcoming BOSU survey will help us to determine the frequency of the rarer sight-threatening complications. Certainly there's a lot of mild inflammation, but sometimes patients get long-term persistent inflammation with pressure. Discomfort's probably irrelevant or less relevant. IOP spikes in the trial were very rare, and certainly less rare than has been described, but there are case reports of unusual things happening, macular edema, and certainly there is a story of endotheliolitis in some patients. Some patients are getting changes in their cornea and endotheliolitis, which can, in a very small number of patients, lead to the development of permanent, significant new astigmatism that wasn't there previously. And that's been described in a number of situations. A number of case reports have described cystoid macular edema, and I've certainly seen that now in 3 patients with pre-existing predisposing features. And lastly, there is the risk that if we don't talk to our patients properly, they will think that they've been treated for life, and they will just push off and not come back for many years, as one letter in Australia described somebody who had really slightly missed the point and did not get themselves checked up despite having had their laser. So in summary, we've got a drop-free disease control with stringent target pressures in a lot of patients, 3/4 at 3 years, needing fewer surgery, no sight-threatening side effects, very safe, with less rapidly progressing or fewer rapidly progressing visual field eyes, and less field loss. And SLT was at least, if not perhaps more effective when repeated. So I would propose we should do it for all of our new patients, and certainly I think we should be doing more. Thanks to the team, and thank you very much to you guys for listening. And as a final parting shot, I will just leave you with the thought that maybe, just maybe, we won't need to do laser through a contact lens after all, and the Belkin Labs direct SLT with laser passing through the limbal corneoscleral junction to reach the trabecular meshwork from the front of the eye may well be a very real possibility. It's certainly been in the bottom left hand there, you can see a graph of study eyes, small number of study eyes versus control eyes, showing that control being the SLT and the study being the direct SLT, showing that you can get a pressure response by firing the laser without using a contact lens from the front. and we're currently conducting a randomized, or participating in a randomized controlled trial comparing SLT with Belkin direct SLT, and it'll be very exciting to see what happens from that. So thank you very much for listening and for your patience, and sorry to overrun slightly due to a little bit of IT hiccup. Thanks.
Brilliant. Thanks very much, Gus. Sorry you don't get the round of applause because people can't even unmute themselves. There's a few questions that have come in. I'd like to ask the first question, if that's okay. It seems a really striking finding for me is the incident cataract. That was a really big difference between the groups, which suggests, well, I mean, I doubt SLT protects against cataract. So is this suggesting that prostaglandin analogs in particular, or any particular class? I mean, that's a striking effect within a short period of time. Do you have any comments on that?
I think it's a very striking effect. We certainly know from previous studies that drug exposure does cause earlier onset incident cataract and worsening of pre-existing cataracts. That's been well described from a number of RCTs over the years. I think the Oates published on that as well as others. What's interesting is that that's happened in the prostaglandin era, where the majority of patients, those 2/3 of eyes, were on monotherapy, and the vast majority of the monotherapy was prostaglandin. The vast majority of that prostaglandin was preserved. So whether that's a benzocaine chloride effect rather than a drug effect, we can't, of course, say, but that's my hypothesis. It had previously been considered that beta blockers were pretty bad for your lens, and people had hypothesized that a switch to latanoprost 20 years ago would see less drop-induced lens opacity. Clearly, that doesn't seem to be the case, and it clearly still seems to be a valid effect in as you say, a very short period of time. We did wonder whether there was any sense of bias there, a possibility of bias. Maybe if the medication group had less pressure control and the doctor treating them knew they were taking drugs, so might be more inclined to take their lens out as a pressure control mechanism, could be truly objective and masked. So to avoid that, or rather to look for that, we compared the visual acuities of the groups that were having lens extraction, the visual acuities of the groups that did not have lens extraction, between the two treatment arms, and they were comparable. So the vision threshold for lens extraction, cataract surgery, was the same in the medication group as the laser group. So it seems that they seem to be, that choice seems to have been made at the same threshold for the two groups. So it's not simply a bias introduced by pressure control, although we can never be entirely certain. So yeah, yeah, very striking, and it's continued to persist. I mean, I think the laser group's caught up a little bit. I was worried the laser might, with its slightly inflammatory mechanism, might have caused a little bit of cataract itself, but clearly it's caused less.
Yeah, amazing.
Sorry, that was a long answer for a short question.
There's been a couple questions about the use of of Ocular, whether you think that would have affected the IOP lowering efficacy. Some reference to the SALT trial, which
we chose to use Ocular when the patients had pain, and left it up to them as to whether they had enough pain to be worth using it, as a surrogate for what we thought might be excess inflammation. So we said use the drops if your eye's very sore, but don't use it if it's just a bit irritable. So you've got something that you can use as pain relief. On the hypothesis that using an anti-inflammatory might reduce the required inflammation for pressure control. I'm a bit worried about the SALT trial being extrapolated too widely, because the SALT trial, which looked at the use of steroids, non-steroidals, and placebo in post-op SLT treatment immediately after the laser, and seemed to have found that the anti-inflammatory groups did more. They didn't specify or pre-specify how the laser should be carried out, and so there was quite a wide variation in how the laser was done. And they didn't randomize or stratify on the basis of extent of treatment. So they've actually ended up with a slightly greater proportion of patients in the group that had post-op steroids and non-steroidals having had 360 laser, and a slightly higher proportion of group patients who had nothing having only had 180 laser. And we know that 360 is better than 180 because it does more. Nagar's study from St Thomas's years ago showed that quite clearly. There was a dose-response relationship between the extent of trabecular meshwork treated and pressure response, and that's why we chose 360 for this study. So I fear that that may be a confounder. So I don't quite believe it, and I haven't changed my practice as a result. It's also a very short-term outcome. I think I only had 9-12-month outcomes, and I worry that it's reduced the long-term remodeling. So until they present the 3-year outcomes and reanalyze with a model that includes extent of angle treatment, I haven't changed my practice on the basis of the SALT trial.
Thanks, I think we've got time for one more question from Sheila. What's your view on doing SLT during the pandemic?
I haven't done an SLT during the pandemic because it requires, even if it's only 5 minutes, it still requires 5 minutes at the slit lamp very close to somebody, and there are alternatives. So a lot of patients have had, the patients who respond best to SLT are the patients who would also respond to medication. So the patients who do badly with SLT are the patients that probably need surgery and are already on, 2, 3, God forbid, 4 medications. So I haven't been doing SLT because it's been, I think, safer for people in a COVID era to have been given a prescription and we'll postpone the SLT until we've got the greater safety mechanisms in place. It may be now that we know a little bit more about droplet spread. We've got extensive PPE, personal protection equipment in place, mask wearing for patient and doctor, and breath screens up, that we can go back to doing SLT as much as we were. But in the current era, I cancelled all the SLTs I had booked and I gave them medication until things quietened down.
Great, thanks very much indeed, Gus. So we'll move on to our next speaker now.
No, thanks very much, everyone.
Cheers. Don't know, Sheila, if you can share your screen. So Sheila Luck is a current clinical fellow in the glaucoma service at Moorfields Eye Hospital, and she'll be presenting a case called Laser in the Dark. Thanks, Sheila.
Hi, can you see the slides?
Yeah, very clearly.
Great. Hi, everyone. So follow after the light trial and laser, my talk is Laser in the Dark. So it's a case that I met 3 years ago of this 14-year-old Afro-Caribbean boy. He has right nevus of Alta with secondary glaucoma. He presented to Moorfield when he was 10 weeks old and then had a goniotomy when he was 4 months old. Then later on, he required trabeculectomy, multiple needling, 5FU injections, and finally a tube implant to control his pressure. So I met him 3 years ago when he was 10 years old, and noted that he has some new changes in his peripheral iris with some PAS and a pressure of 23. These are his disc OCT images showing the asymmetry of cupping of ratio 0.8 on the right eye. And interestingly, looking at the OCT parameters, because of his age and his healthy retina, the retinal nerve fiber layer thickness is still deemed to be within the normal, but you can see the marked asymmetry between the eyes. So because of the changes in his iris and the high pressure, he was listed for EUA and cyclodiode laser, and these are more images from him. So you can see these PAS developed from about 7 clock hours to 10 clock hours, and the tube is in situ in the superior temporal quadrant. So further imaging showing more detail of these PAS, but luckily there's no mass identified. And in the OCT, you can see this hyperreflectivity on the surface of the iris. Again, no mass being identified. And I'll come back to this hyperreflectivity later. So B scan we did and also rule out any uveal tissue tumors and no choroidal involvement. So given there's no tumor, we can proceed with the cyclodiode laser, and we plan to do 20 burns. The usual setting, we started with 15,000 milliseconds and 1,500 milliwatts, and we want to avoid the PAS area. As we were doing the inferior area, we noticed some conjunctival perforation. So we switch on the operation theater light and notice some partial scleral burn. And we titrate down the laser power, and then at the end we dissected out those damaged conch and suture it down to the limbus with the free healthy conch with the 8-0 vicro, and he made an uneventful recovery. He was then seen by Mr. Sagu with all the images, and luckily because of his age and from an Afro-Caribbean background, he's deemed to have low risk for develop malignancy, but he should still carry on yearly ultrasound monitoring. So to finish off the story, for the last 3 years, unfortunately, he still have pressure creeping up and requiring a second chip implant in the superior nasal quadrant. He was seen by Mr. Sagu again in 2018 because the iris changes now have some whitening depigmentation. But fortunately, again, there's no mass identified and continued yearly follow-up with ultrasound. The last review was done last year, December 2019, with a vision of 6/7.5, pressure of 16 on 2 drops, with a cup disc ratio of 0.9. As you can see now, there is definitive thinning, superior temporal and inferior temporal area, with a gradual reduction of the retinal nerve fiber layer over the years. So, nevus of Volta, or oculodermal melanocytosis, is the blue-gray hyperpigmentation that occur in the eye and the skin on the face. It's due to overpopulation of the melanocytes. It's rare amongst Caucasian, most frequently affecting the Asian population, and most cases are unilateral cases. It's affecting more women than male with a ratio of 5:1, and most cases are present as a congenital lesion. However, these lesions can increase after puberty or postmenopausal state, and thus raise the query whether it has a hormonal component to the pathophysiology because of these changes over time, and also more affecting female than male. So ocular signs, 2/3 of patients would present with pigments in the sclera. However, pigments can deposit in cornea, retina, and optic disc as well. And I'm going to focus the next slide, this one, on some iris pictures. So as you can see, iris heterochromia can develop in the in the top right corner images. And the iris nodule or mammillations. So you can see in the bottom right picture with these little nodules that occur on the iris surface. And if you do UBM, you will see hyperreflectivity on the iris profile and surface, which is identified in our patient as well. And other iris changes include loss of iris crypt has been developed. And depigmentation has been reported as well, so it can occur in more sectoral fashion in the left-hand side, or more diffuse on the top right-hand side picture. And cavernous hemangioma has been described as well. So unfortunately, 10% of these patients with nevus of Volta can develop pressure problem or even develop glaucoma. That's because of angle abnormalities, because of the neurocrest anomalies. The other mechanism is because of the blocking of the open angle by the melanocytes, as you can see from the gonio picture on the right. Various surgical treatment has been described, such as goniotomy, trabeculectomy, traps, and also cheap implant to control the pressure. The other problem with nevus of Volta is the malignancy transformation. So various paper has different risks, but one of the latest paper quotes that about 7.5 patients develop uveal melanoma, and most patients have developed either choroidal or ciliary body tumors. So in the picture in the bottom is a picture of choroidal melanoma with associated serous retinal detachment over the B scan on the bottom right picture. So unfortunately, not only they can develop malignancy, but also they have a higher risk of developing metastasis compared to other age-matched patients. So they definitely require yearly, lifelong monitoring, or some patients may need twice yearly monitoring. Orbital melanoma has been described as well, so patients can present with proptosis of changes of vision, and that has been reported. So Tanino classification is the most frequently used classification for this condition. For us as an ophthalmologist, it's probably not as useful because they lump all the orbital sign into this 1A, so probably more useful for dermatologists. And yeah, so this group recently published in BJO, in the Israeli group, looking at 40 patients with this condition, and they proposed this new classification to subgroup that patients according to which eye structure being affected, whether the sclera, iris, or in the fundus, and how many quadrants being affected, because then we can link to the risk of tumor and glaucoma, and therefore we may be able to improve our risk stratification in terms of monitoring and also better inform patients regarding their risks. So I'm just going to touch on optic disc OCT on children. And so I found various papers. So the average thickness is about 95 microns thick. And in most paper, they found that in the normal children, the eye thickness should still follow the Isant rule. However, in one of the paper from BJO, they found that the superior quadrant just on the left side is thicker than the inferior side. So the actual number may not be as useful, but we must look at the asymmetry. So if there is differences more than 10 microns between the two eyes, or the cup disc ratio, vertical cup disc ratio more than 0.2 difference, then they should be considered for further investigations. So just going back to our kid, this was in 2005. So although the number is way beyond 100 microns, but you can see compared to the left eye, there is asymmetry more than 10 microns in the superior and inferior quadrant. And lastly, so our patient developed some scleral burn from the cyclodiode laser, unfortunately. That's because for children, the juvenile collagen are more susceptible to heat damage. And also together with the increased pigment, they absorb more laser energy and therefore causing more damage to the tissue. So the learning point is that we need to titrate down the laser power when we're treating pigmented tissue, for example, in nevus of Volta or Sturge-Weber or other condition. And we usually, when we're doing the diode, we're concentrating on the tissue ahead, but even in the darkroom, we must observe the tissue that we just treated to make sure that we do not develop any complication. So that's it for my talk. Thank you very much.
Great, very interesting case. Thanks very much, Sheila. If there are any questions, please enter them into the chat. That's quite worrying, the reaction that you can get to diode, as you're saying, in a juvenile eye.
Yeah. We didn't
pardon?
that part. We didn't actually hear any pop, and then as we move along, then we saw it. So it's something that we need to be aware, especially pediatric case or pigmented cases.
And that's to the sclera as well as to the conch, is it?
Yes, so we can see some mark on the sclera, but there was no perforation. It was, I think it's quite superficial. So we just, yeah, as I mentioned, we then cover the sclera area that's been affected with the healthy conch and made an uneventful recovery.
Yeah. I mean, I just wonder whether, even if you don't see anything like that, because the power is lower, I wonder whether you're still potentially inciting something that might not become apparent for, till months or years later, like severe scleromalacia. And I've certainly seen, and you can sort of almost get the sclera expanding and bowing out in the future. So should we be avoiding laser overall in these patients? Sorry, Gus?
No, I was going to say, you certainly see some patients who've had pediatric diode sometime later with, I've seen patients with clear marks where each laser burn was with scleromalacia at each of those points. So there is quite a, and not with excessive laser. So clearly there's a range of tissue response to the inciting inflammation caused by the laser.
Yeah.
I think we've got to be very careful with it, particularly in younger patients.
Yeah. Thanks very much, Sheila.
Thank
okay,
you.
so our last presentation today is from Giovanni Montesano, who's going to tell us how to recruit to glaucoma trials such that we need the minimum number of people to see a difference between the arms. I think I got that right. Anyway, over to you, Giovanni.
Yeah, pretty much. Yeah. Okay, so hopefully you can see my screen.
Not yet.
Not yet. Okay. Oh.
So while you're doing that, I'll just remind everyone, Giovanni is a research fellow at Moorfields Eye Hospital, but primarily at City University, working in the Crab Lab. Thanks, Giovanni.
Okay, thanks for the introduction. This you can see it fine now, right?
Yeah, very
you can
clear.
See.
Yeah, perfect.
Yeah.
Thank you, Giovanni.
I can see you.
Okay, great. So basically this was supposed to be essentially my ARVO talk, and this is why I'm showcasing this ribbon of the travel grant that unfortunately I didn't get to use this year. The focus of the presentation is to understand whether by selecting people that are more reliable visual field test takers, we can improve the power of glaucoma trials. So specifically, we wanted to target the issue of neuroprotective treatments, and the reason for that, so the ideas behind our work apply to any glaucoma trial, but essentially when we talk about a neuroprotective treatment, we expect to have a treatment that slows down or halts completely the progression of glaucoma, and this progression is usually measured with visual field test series. The problem, especially with neuroprotective treatments, is that the effect magnitude is expected to be small, mostly because we will be delivering this treatment on top of standard glaucoma care. And this makes the detection of any effect much more difficult. And on top of that, the noise in the visual field test series heavily depends on the patient's ability to perform the test. So essentially, the objective of the work was to calculate a variability index that allowed us to identify reliable test takers and to test whether recruiting these people more in the trials could improve the power of the randomized clinical trial for neuroprotection. So to test this, we use simulations of visual fields to mimic what would happen in a real clinical trial. And we seeded our simulations with a large sample of glaucoma or visual fields from glaucoma patients from 5 UK glaucoma clinics. We have used this database in previous papers, and this is the general description of the database. We have more than 70,000 people and more than 500,000 visual field tests. But for our analysis, we only selected one eye per subject. We only kept visual fields that had less than 15% false positives, and the series were a mixture of CETA standard and fast, because that's what happens in real life. We also only kept visual field test series that contained at least 10 visual fields over a time span of 4 years. And we also selected people that had a mean deviation lower than 2 decibels, than -2 decibels in at least 2 visual fields of the series. We have used this selection criterion before, and this is mainly meant to account for the lack of a clear label for a diagnosis of glaucoma. But we figured out that with all these criteria and the fact that the people were so long follow-ups, this level of mean deviation consistently, and the fact that they were all coming from glaucoma clinics, they should be at least be glaucoma suspects. So the final selection included 2,735 people. These are some descriptive statistics of the sample, median interquartile range of different important variables. Approximately 30% of the people had cataract surgery within this follow-up period. And these are the mean rate of progressions of the mean deviation. We have divided this calculation into 2 groups for the first 6 fields in the series, and for the rest of the series. The reason for this will become clear in a second. But the only thing that we might want to notice in this case is that for the first part of the series, the rate of progression was much less, and this is probably due to a learning effect as the patients learned how to do visual fields. So the way we calculated our variability index was very simply to plot the mean deviation over time for each patient, and then we fitted a regression line through the mean deviations, and then we calculated the standard deviation of the residuals, which is very simply just the distance of each point from the regression line. And we did this for the first 6 visits in each visual field series. Then we did this for all patients, and we ended up with a distribution of this variability index. And you can see that it can vary quite wildly, from people that are more repeatable to people that are much more noisy. And this is what we hope to capture with this index. Then the reason why we only used the first 6 visits is because we wanted to use the rest of the series to generate our data simulations, so that within the same subject, the selection phase and the trial phase were independent within the same subject. For our simulations, we heavily relied on the method developed by Medeiros' group a couple of years ago, with very slight modifications. We don't need to delve too much into the technicalities of how the simulations were done, but essentially the core idea is that we can fit regression lines at each location in the visual field. So here you have sensitivity over time for each location. And if we zoom in on one of the locations, we can see what we've done. We just fitted a regression line, a straight regression line to the points. And again, we have the residuals, which is just the distance of each data point from the regression line. And we call this the prediction from the regression line, the predicted sensitivity that we assume to be the true value in our simulations for that point in time for that location. Then we can estimate our noise for each location from the residuals. So if we now plot the absolute value of the residual, so the noise versus the sensitivity of each location, we can observe the typical pattern that we see in visual fields, where we have that at lower sensitivities, we have higher variability, so higher noise. This is nothing new. This has been known for a long time. But essentially the idea behind the simulations is that if we can sample from the distributions of this residual for any given sensitivity to introduce noise in our simulations and mimic what we see in real life. There is another additional problem with simulations, and that's the fact that the noise at each location is actually not independent. And we can see it clearly with an example. So if we follow the sensitivity in the whole field from this time point to this time point, you can see that, especially in the lower part, there is a global downward shift of the field. So the noise at each location doesn't apply independently, and there will be days where the field will be boosted up, and days where the field will be globally depressed. So there will be good days and bad days that will affect the whole field as a whole. And the good thing about the modeling approach that we've chosen is that we can capture this. This has been studied before. It's known as the global visit effect, and also has an important role in determining progression. We can visualize this with an example. So here at the bottom you have a real visual field series, and you can see it's quite variable. This is an illustrative example because this is a very badly behaved patient. And you can see that if you only use local noise, you don't have an accurate reproduction of the fluctuations that you have in the whole field. And the noise in your simulations will be much lower than what you would have in a real series. And the reason is that if you apply noise at each location independently, especially when you take the mean deviation, which is what we're plotting here with the points, the noise will be averaged out. And so this is not an accurate reproduction of what we actually see in real life. Instead, if we account for global fluctuations in the simulations, and we can do this, we can see that now the variability of the MD is much closer to what we have in real life. So the good thing now is that we have our simulation machinery that that is able to take in data from the real visual fields from the second half of the series, and then generate visual field test series of a would-be trial at our arbitrary time points. So we can decide the scheme of the trial. For our simulations, we use the UK GTS scheme, which has 16 fields over 2 years, and importantly, it preserves the variability of each individual. And this is especially important in our case because if we didn't preserve this variability in the simulation, then our selection based on the variability index wouldn't make sense. And the reason why we also need simulations is that if we want to simulate a neuroprotective effect of any effect of any kind, we can do this with simulations because we can introduce this by modifying the slopes that we use to evolve the visual fields in our simulation. So this is what we usually do in clinical trials and what we actually do in simulations. And in this first graph, this blue line represents the cumulative counts according to the variability index. So basically, if you just order your subjects according to the variability index and you count how many people have a variability index that is lower or equal to the value that you see here on the x-axis, you just count them, you have a curve like this. So basically, as you relax your inclusion criteria, you will include more and more people. It turns out that what we do in normal trials, we completely disregard this information and we sample people at random. So, for example, if we need to reach a sample size of 20 in this case, we're just randomly sampling people from a data set, and then we randomly, once we have recruited them, we allocate them to either the placebo arm, where we have no neuroprotective effect in our simulations, and or the treatment arm. And in our simulations, we have simulated 3 levels of neuroprotective effect: low, intermediate, and large. And what we do at the end of the trial, so after we have run our simulations with the different effects, we calculate the difference in the rate of progression of the mean deviation between the 2 groups. We repeat these simulations 1,000 times for each effect size. And the power of our trial is simply the proportion of simulations where we had a p-value for this comparison here that was less than 0.05. So, of course, we can then repeat the same thing for a larger number of people. So in this case, it's 1,500 with the same scheme. We just randomly recruit people, and we run the simulations as before, and we calculate the power. So the recruiting method that we are proposing in this work is that we preserve the order of imposed by the variability index, and we start off by recruiting people that are the least variable, and then we gradually increase and relax our inclusion criteria to include more and more people until we reach our desired sample size. And then the rest of the simulations or the would-be trial is run exactly the same way. So now we can plot the results, and we can compare the two strategies in terms of power. So we plot the power of the trial, so the ability to discriminate between treatment and placebo on the vertical axis, and on the horizontal axis you have the total number of subjects included in the trial. Of course, we would expect that for both strategies the power would increase with increasing number of people included. So if we look at the plots, we can see that the power is much higher in every case for any effect with the selection that uses the information about the variability of the subject. And this dashed line here is the 80% threshold, which is of power, which is a usual threshold that is used in many clinical trials. And as you can see, the number of subjects needed to reach this threshold is much lower, by more than 50% lower with the smallest variability selection criterion. So with the strategy that we have proposed, and even at the same sample size that would be required to have 80% power with the random selection, so with the way we usually do now, we would have a much higher power. So we call this difference in power the equivalent power of a selected strategy. So this is just the same results reported in the table. So you can see that for the same number, this is the equivalent power. And you can see that for the same number where we would expect 80% power with the random selection, we actually have between 97 and 98% power with our improved selection strategy. So in conclusion, we have shown that selecting people or recruiting them, preferentially recruiting people that are better test takers in trials, can reduce the noise and then improve the power of the trial, and that this can be done with a very simple variability index that can be calculated with with data that are easily retrieved from any electronic medical records. This is the end of my talk. I just wanted to thank my mentors for this project, Professor David Crabb and Dr. Harry Quigley, and also all my colleagues from the lab. And thank you so much for listening, for your attention.
Thanks very much, Giovanni. What a beautiful presentation and great data visualizations. If anyone has any questions, please pop them into the chat. Maybe I could have the first question.
Yeah.
Giovanni, but glaucoma is a complex disease, and probably primary open-angle glaucoma is lots of different diseases that kind of look the same, right?
Yes.
Is there a possibility that this test variability is a marker of some types of glaucoma but not others? And therefore, if you're selecting people for trials that have less variability, you might be selecting for a certain type of glaucoma, and therefore your neuroprotective treatment, the results of that, the effectiveness of that wouldn't apply to your glaucoma population in general.
Yes, this could be the case. So I'll just bring up like a hidden slide that could be useful for this question. So this could be the case. So in this selection, I think that in the selection that we've used, we have excluded people that had a clear label. We only use primary open-angle glaucoma people. So we excluded people that had clear labels for different types of glaucoma. But then again, this could not be, this no guarantee that we're not selecting subtypes of glaucoma people. This slide, the only thing that I was able to quantify in that regard is the effect of the effect of selecting people with different cutoffs for variability on the mean deviation, so the amount of damage, but most importantly on the rate of progression of the sample that we were selecting. So basically, I was just trying to see whether we were with low variability, we were hyper selecting people that were more stable or less damaged. And this is, on average, this is certainly the case, especially for the mean deviation, as you can see here. But the spread of the values are actually, I think they are wide enough that they can always, across the spectrum, they can always be considered fairly representative of the general population. So that there is some selection, that there is some hyper selection of people, at least from what we can see from the level of damage and from the rate of progression, so from the speed of progression. I think that the range, though, of the sample that we select is large enough that this can still be representative of the general population.
Brilliant, thank you. And a question from Alan. What is the minimum number of visual fields you need to calculate the variability index?
Okay, so I didn't investigate this thoroughly. So exactly how many fields you need to calculate the variability. I think I've only looked at 4 and then switched to 6 because I remember that 4 was not giving me much prediction of how, so it was not giving selecting with calculating the variability index with just 4 fields and then using that to select people for the trial was not giving me a great boost in power. So I would say that definitely not 4. It was giving me some gain, but nearly not enough. I think that 6 is a good number, but I don't have any hard evidence to base this sentence on. So yeah, okay. I didn't explore that specifically.
And just one last thing, if sticking your head in a bowl to do visual fields is going to be a historical thing, something of the past following the pandemic, do you see this working for other forms of visual field testing?
Yeah, this has nothing to do with the specific type of visual field that we do, and actually it could be applied to any test really, any psychophysical test. So I actually think that it would be more useful if we switch to something for if we switch to something like home monitoring, because ideally we would have many more visual fields, a longer history of visual fields with many more visual fields for each patient to base our calculation of the variability on and the simulations. So I would say it is going to be even better. This could be applied even better to other types of visual fields, especially if they can be delivered, at home, and we can gather more.
Yeah, absolutely. Very exciting. And also, I think one last, well, a couple comments. David Crabb, one of your mentors, is asking whether you tried the study with and without the false positive criteria, whether that was important. And then Andrew and Sheila are both aligned here, wondering whether you might be selecting people who are more compliant with medication, which I guess generally recruiting to a trial always has that bias. You always recruit more compliant people. But anyway, your comments on those two questions?
Yeah, so they're kind of related in the sense that we didn't include in our first selection of the sample, we didn't just go for anybody. So we wanted to be reasonable and be realistic, and because that's a thing that we do. We don't just ask anybody to participate in the trial. If we have people that consistently fail at meeting the reliability criteria for visual fields, especially for the false positives, we don't recruit them. So of course this database doesn't capture the information on reliability, and it would be kind of a stretch to assume that people that can't do fields are also going to be unreliable with the medications. Maybe that's the case, but I don't have anything to say that, so I couldn't. That's a thing that I cannot explore. Definitely the criterion that we use for false positives was very strict. 15% is quite strict, because I just thought that was more realistic applied in recruiting people for trials. So you don't just want to bring anybody in, but the threshold that is usually used for reliable fields is 33%. So we might include more people, so by relaxing the false positive criterion. But I think that would only make the selection stronger, because we would be increasing the number of unreliable people. So we would make our selection based on variability even more important for the trial than it is in this case, where we have over-selected people that already are relatively good test takers, at least according to the usual metrics.
Okay, well, thanks very much, Giovanni. That probably was no replacement for getting up on the podium at Arvo, but still, I'm glad you were able to share your amazing research results with us on this platform. Okay, well, thanks everyone for attending. There will be a session next week, agenda to be confirmed. We will be starting a bit later because we have an internal meeting, so next week will be at 10 a.m. Thanks all for joining, and see you next week.
Thank you.